All right. So, hi, good morning, everyone. Uh, so, another day, another morning, another 5 a.m. session. All right. So, I'll just wait for a couple of seconds so that other people can join in and we can start. All right. So, guys, last for some time, for a couple of days, we have been discussing like 2 or 3 sessions we have done for your pyqs of all the FMG examination. Good morning, and Zamamul. Okay, Yashwant, good morning. So I think 2 sessions we have done, and the number third session got postponed. And yesterday I had some issues with the Instagram account. Something got wrong. I announced and I couldn't take it. So anyhow, now we are starting with the session 3 today, and I'm sure that with these only some kind of 20 days remaining for the exam, you all are prepared well, geared up well. And I know it becomes quite difficult. It becomes quite uh, you know uh, very tough to get up early in the morning and then align yourself with the examination time. But you all will have to understand gradually that with these 20 days left for the exam, you all must develop an habit to get up early in the morning and align yourself uh, with the day of the exam. And your mind should be most active at the time when you're supposed to give your exam only, right? So just start changing your routine lifestyle, just start changing your daily habits, and that is going to help you out in your exam as well. All right. So guys, today I'm going to start with the day 3 of your these pyqs. And once these pyqs from your own workbook are completed, after that I'll take the recently asked MCQs of the this current session and of the previous year as well, and highly expected questions which are asked in all your exams, or highest probability of being asked in any of your exam, whether it is FMG or the NEET or the INSET exam. Okay, so we'll go like that. So let me just start with the day, and just give me a moment so that I can show you something, the quote of the day. Let me just shift this mobile on the stand here now. So I think that will make things easier for you as well, for me as well. All right. So I hope you all can see this. So that's a quote for all of you, that action is the key to all success, right? You keep on saying, and you don't do it. It's not going to, make you reach anywhere. But you start working, it is a surety that something will happen, right? So failure or maybe the success, it is always the secondary thing. What is the most important primary thing is to start working on that, right? So action is the key to all success. You all should work upon wherever your negatives are, wherever your shortcomings are, and that is going to help you out in your exam, right? That is something which you all should follow, which I'm trying to follow, so that all our desires, all our aims get fulfilled, and that is how we are supposed to work. All right, so let's start the day. And that is your paper. So in the previous 2 sessions we have done till this was your paper of which year? December 21 we have already done, and now we are on to the June 21, right? December 21 was done, and this is the June 21 exam. Let me just adjust it a little bit. I hope the question is visible to all of you. And see, these pyqs you all should take very seriously, because when you look at them, they are the most important and the most expected questions for your exams, right? So let's start, and I'm expecting each one of you to participate in the answers, and let's see where all we can go wrong and where all we are right. All right, so let's start with this. So good morning Daud Mani, good morning bache. Let's start with this. So the first question goes like this: what are the keywords? Number 1, alcoholic. There must be some reason why is giving you alcoholic, right? An alcoholic patient. Yeah, now I think it is little better. Alcoholic patient slept on his chair after having too much of drink, right? He is not conscious. On waking up, he noted a compression and tingling around his arm region. Okay, on examination, injury to the radial nerve was concluded. And you know very well that when you are talking about an alcoholic, and that too the radial nerve, getting involved, what do you call that? What do you call that kind of insult to the radial nerve when an alcoholic sleeps with his arm over the edge of the chair? What do we call that? So the drinks on the Saturdays, right? The drink on the Saturday, and that is Saturday night pilsy, right? That's what you call as the Saturday night pilsy, right? I'm very sure that you all are aware of this, the Saturday night pilsy. And most often, what kind of injury is Saturday night PLC. You know, this classification which is mentioned over here, is what kind of classification system? It is the one which is given by Seddons, right? It is given by Seddons. So Saturday night PLC, the Seddons classification, when you have to divide it, right, then how do we say what kind of injury it is? Most often it is a neuropraxia, right? Most often it is a neuropraxia. So please don't forget about this, the neuropraxia, right? And I want everyone to remember this, the Saturday night PLC. See, the radial nerve and the classifications. The radial nerve and the classification, they both are very, very important. So let me show you something here. See, I want you all to remember something from here. I want you all to remember this. Yeah. So this one, just give me a moment and I'll show you something. So this classification system, as well as your this. Yeah. So let me just open up. Yeah, so this is yeah, okay, I can show you from here. Look at this radial nerve. First of all about the classification of the nerve injuries, right? So I want you all to remember this classification system. Okay, this one is which classification system? This is very, very important one, and this is called as Seddons classification. How does Seddons divide the nerve injuries? Seddon is very important for your exam also. See, in Seddons classification, you are supposed to learn 3 grades of nerve injuries. Which ones? Number 1, neuropraxia. Seddon number 1 is neuropraxia, right? Number 2 is exontemesis, okay? Exontemesis. And number 3 is neurotemesis. Don't forget these 3 injuries, okay? Neuropraxia, exontemesis and neurotemesis, right? Now, what exactly are the details of these injuries? See, when you look at the details of these injuries, neuropraxia simply means a physiological conduction block. That means when the nerve is involved, it is just physiologically, compressed. And whenever you relieve the pressure, the nerve will get fine, right? And the commonest example you should know is Saturday night PLC. That is why we always believe that every patient of ours is going to get fine without any treatment. Just wait and watch with the Saturday night PLC, right? Every patient recovers absolutely. Second grade of injury is injury to the axon, that is called as exontemesis, right? Exontemesis may happen with or without injury to the endoneurium. And neurotemesis is complete transaction of the nerve, where definitely the repair is required. Now I want everyone to remember this Seddons classification, right? I'll share the same screenshot in my stories as well, in my orthopedic group as well. Okay, so Seddons definitely everybody is supposed to remember. This is very, very important. The classification system. Okay, number 1. Now number 2 is to know about the radial nerve injury. At what level the radial nerve involved will lead to what kind of presentation. Now just understand this from here itself, okay? I'll hide unnecessary things from here so that this paper doesn't look too occupied. Now see, this image is showing you the course of the radial nerve, okay? You all can make out. This is showing you the course of the radial nerve. Now in course of the radial nerve, look at this. This is the proximal humerus, which is articulating with the glenoid area, right? Which is articulating with the glenoid area. Now this is a simple way to remember everything about the radial nerve, right? Now there is the radial nerve, how it goes down. The radial nerve goes down from the medial side, along the medial side of the shaft here, and then from the posterior side, it crosses the humerus shaft, spiral groove, and then it comes on the lateral side, right? In front of the lateral condyle, it divides into 2 branches, okay? One which is very, very superficial, and one which goes behind the interosseous membrane, right? So the one which is superficial here, this hard line here in the blue, it is called as the superficial branch of the radial nerve. And this dotted line here is the posterior interosseous nerve. It is going behind the interosseous membrane, right? So superficial branch, this hard line, dotted line is the posterior interosseous nerve, right? This is a course. So nerve in the upper part, it stays on the medial side, then it goes behind the spiral groove, then it comes on the lateral side. Now see, you can easily remember it by learning the course of the nerve and the supply to the 2 major muscles. Which 2 major muscles? One is triceps here. You can see this one. The triceps long head is supplied when the nerve is on the medial side. Triceps long head is supplied when the nerve is on the medial side, right? Lateral head, medial head are supplied when the nerve is in spiral groove. Okay. So first muscle to get a supply is when the radial nerve is on the medial side, right? And the other 2 heads are getting a supply when the nerve is in the spiral groove, right? Then there is a nerve which is getting a supply just before the bifurcation. Which nerve is that? which muscle is that? It is extensor carpi radialis longus, right? So just pay attention to this very, very carefully. This is the most important part. Nerve first is on the medial side of the shaft, then in the spiral groove, and then on the lateral side, right? Here it divides into two parts, one which is very, very superficial and one which is behind the interosseous membrane, right? Now, see, we have four components mentioned here. Number one, if I say triceps, number two, ECRL, number three, posterior interosseous nerve, and number four, superficial branch, right? What is the action of each one of them? Now look at this ABCD, the small ABCD, if you can see on my screen. Now see, what are these small ABCD telling you? Small ABCD is telling you the four functions of these four, structures. Triceps, what is action? Extension of elbow, triceps. What is action of ECRL? Extension of the wrist. What is the PIN job? To help in the extension of fingers. And what is the function of the superficial branch of the radial nerve? Sensation at dorsum of hand. So we have got action A, B, C and D, right? A, B, C, D by your four, these components here. Now let's understand, if injury occurs to any of the structure at any level, if injury occurs to these structures at any of the level, then what will be the presentation of patient? Now understand this. In axilla, I'm marking in black now. In axilla, if injury occurs in axilla, there is no muscle which has been supplied yet, right? If the injury is here, there is no muscle which has been supplied yet, right? Now, if the injury occurs over here in the axillary region, what is going to happen? All the four actions are lost, right? No extension of the elbow, no extension of the wrist, no extension of the finger, and sensory loss. Everything is gone, right? So this is what we call as the crutch palsy. This is what you call crutch palsy, okay? Now, if injury occurs in the spiral groove here, number 2 in the black, if the injury occurs here in the spiral groove, what will happen? The long head of triceps has already got a supply here, but the lateral head, medial head is yet not got the supply, right? Lateral and the medial head has yet not got the supply. That means partial power of triceps will be spared, right? Partial power of the triceps will be spared. So, now out of these four actions, action A, B, C, D, extension of elbow will be little weak, but all the other three actions, that is extension of wrist, finger and sensation, they all will be lost. And this is what we are learning here as the Saturday night palsy, right? This is what we are learning as the Saturday night palsy. So spiral groove will have a weak extension of elbow, but loss of extension of wrist, fingers and sensation. Now, if there is an injury to the shaft of the humerus, extension of elbow has been supplied very properly above this. Okay, so extension of elbow will be maintained, but extension of wrist, extension of fingers and the sensation, all the three, the B, C and D, they all are lost. Okay, and if there is an injury around the head of radius, then it is going to affect the posterior interosseous nerve, which will cause a failure of the extension of fingers. So finger will have a droop, right? Finger will have a droop. So, okay, so this is what we call as a finger drop. And now this number 4 point you should remember as a case of Monteggia fracture, right? As a case of Monteggia fracture. Please remember this. All right, as a case of Monteggia fracture. So number 1, 2, 3, 4. I hope this picture makes the, this radial nerve little easier for you. Please don't forget, this is a continuation of the posterior cord of the brachial plexus, right? So this radial nerve part is fine with everyone. The Saturday night versus the crutch palsy, the shaft of humerus and the radial nerve injury, radial head injury. Okay, so please don't forget, where do we have the wrist drop, where do we have the finger drop, and where the complete loss will be there. So I'll share this picture as well. Right, I'll share this picture as well, so don't just miss out. This is a very, very important topic. Radial nerve is going to be a very important topic. And one very important point here, see, whenever there is a drop of the wrist, whenever there is a drop of the fingers, we have to keep them elevated, and that is why we keep a splint which can keep the wrist or the fingers elevated like that, and that is what we are calling as a cock-up splint. Now in the splints, please don't forget, any splint can be of two types. It can be a dynamic splint or it can be a static splint. Right, it can be a dynamic splint or it can be a static splint. Now in any splint you see some springs attached, some rubbers attached, some elastic attached, there is a mobility possible. Now if mobility is possible, that means it is a dynamic kind of splint. Okay, so dynamic splint or static splint, please don't forget that. Dynamic splint or the static splint, please don't forget that. So Saturday night palsy, or question number 1 is very, very important one. Right, so radial nerve and Seddon's classification, I want everyone to remember very, very thoroughly, very, very properly. Right, so this is radial nerve and the Seddon's. Okay, number 2, again a very, very important topic. A 20-year-old male, now this is coming from the topic of tuberculosis, right? That is the topic of tuberculosis, that is TB hip. Okay, so in TB hip, they're asking you the question here. Okay, so in this TB hip has been a question of your exam, which has been again asked repeatedly, right? And you should be very, very clear about these pointers. So 20-year-old male coming with 1 month history of the hip pain, right? On the examination, there is true limb lengthening, right? True limb lengthening. And here you should know what stage of TB it should be. What do you say? D, advanced arthritis. Okay, I'll take that advanced. Anyone else? Advanced arthritis or something else? What do you say? Is it advanced arthritis or something else? True limb shortening. The patient was diagnosed as a case of TB, right? 1 month history of hip pain, and on the examination there is true limb shortening. So don't forget, advanced arthritis as well as the late arthritis, both are going to have true shortening. So now here in this particular question, I don't have any keyword which tells me whether it is stage 3 or the stage 4. Now let's talk about this table. Okay, let's talk about this table. This can be stage 3 also, and this can be stage 4 also. See, when you are talking about the stages of TB hip, okay, when you are talking about the stages of TB hip, please don't forget this. See, any joint infection has to start with infection of the synovium, right? Any infection has to start with the infection of synovium. That is why the stage 1 is always the stage of synovitis, right? Stage 1 has to be the stage of synovitis. Now in synovitis, what is the attitude of the hip, if you can recall? What is the attitude of the hip, if you can recall? So attitude of hip has to be flexion, abduction and external rotation. And now synovitis alone is not going to do any change in the limb length, right? So no bone changes. So bone changes will not be seen, right? No bone changes will be seen. Okay, no bone changes will be seen. Second stage is now the bony involvement, right? What is a bony involvement stage called as? The bony involvement stage is the stage of early arthritis, right? It will be the stage of early arthritis. Now in early arthritis, what changes? See, the first one, the flexion stays as such because that is a contracture of the soft tissue. But the capsule now, from the maximal possible capacity, it goes to the minimal possible capacity. And that is completely contracted, flexion, adduction and internal rotation, right? Now in this early stage, we don't have any bony change per se, destruction or something like that. But yes, the pressure effect on the bone can be seen, and that is simply called as the periarticular osteopenia. So if ever in your exam they ask you that what is the first radiological sign seen in the TB hip, the first radiological sign is periarticular osteopenia. Please remember, in the early arthritis, there is no joint space damage, there is no joint space change, right? There is no joint space change. So that is just a periarticular osteopenia, right? That is just a periarticular osteopenia. Now in the stage number 3, it is late arthritis, right? This is late arthritis. Now this late arthritis again will have the attitude will be same. Attitude is not going to change, right? Attitude stays same. But what is the most important feature of this one? Here we now get decrease or loss of the joint space. Decrease or loss of the joint space. Now, if there is a decrease or loss of the joint space, what does that mean? Will there be a shortening or no? Yes, there is going to be a true shortening in this case as well, or in this stage as well, right? So that is the stage of true shortening. So when do we see the first stage of true shortening? It is in late arthritis, right? It is in late arthritis. Okay, that is late arthritis. And now when you talk about the stage number 4, so stage number 4 is basically the advanced arthritis, a damaging one, severely damaging one, right? So stage 4 is now called as the advanced arthritis, right? Advanced arthritis. Now what happens in advanced arthritis? In advanced arthritis, the attitude of the hip, it changes again. It stays same as flexion, adduction and internal rotation. And what do we see here? What do we see here in this case? In this case, what we see is gross shortening, number 1. Gross shortening. And what is a typical radiographic feature called as? What is a typical radiographic feature called as? It is called as the wandering acetabulum. You remember this? The wandering acetabulum. So again, this question is having a very high probability to be asked in the exam, right? This is having a very high possibility to be asked in the exam. So please do mark the MCQs here, right? Do mark the MCQs here. Question number 1. What is the first radiological sign seen in TB hip? That is periarticular osteopenia, right? But don't forget, early arthritis has got no change in the joint space. All right. Now, second one is a late arthritis. And what do we see here in the late arthritis? In late arthritis, we do have true shortening, right? There will be true shortening. All right. So true shortening is seen in which stage of TB hip? It is the stage number 3, that is late arthritis. And when you say advanced arthritis means gross shortening and the wandering acetabulum, right? Wandering acetabulum. All right. You got this point here. So stages of TB hip. Now, one very important one-liner MCQ that I must tell you here. See, when you're talking about the stages of TB hip, you should also remember that where do we get the first foci of TB? Where do we get the first foci of TB? So first foci of the infection, usually starts from acetabulum, right? That starts from acetabulum. So infection starts from acetabulum, followed by the second one is usually the head of the femur. Now understand this. When you look at the hip joint, the head of the femur here, the neck of the femur, the trochanteric region, right? And this is the acetabulum here. Now, if you say this, let's suppose, is the capsular margin, right? So infection first reaches here, right? It can go to the acetabulum, it can go to the head of the femur. So most often the first focus goes to the acetabulum. Why is it different? Not head of femur, Zafa. It is wrong. Head of femur is not right. Okay. This head of femur is the foci for septic arthritis, right? Most common foci for septic arthritis, it is in the head of the femur. Okay. Most commonest is in the head of the femur. That is septic arthritis. Okay. That would be septic arthritis. So septic arthritis, most common foci, head of the femur. That is your question 1. Tuberculosis affects what? The head of the femur first or the acetabulum? So it is acetabulum, right? Acetabulum or the head of the femur. I hope this is fine. Both are your MCQs. Now, how clinically you will make a difference looking at the presentation of patient? Your patients of septic arthritis are the kids usually between the age of 2 to 5 years, right? And there is a very special entity, Tom Smith arthritis. You remember this? Tom Smith arthritis. So Tom Smith arthritis is the septic arthritis of hip. It is the septic arthritis of hip in infants. So Tom Smith arthritis is the septic arthritis of hip in infants, right? So septic arthritis, 2 to 5 years, Tom Smith arthritis, infant. These are all your MCQs. And when you talk about tuberculosis, the most commonest foci has to be in the acetabulum, not head of femur. That is second one, right? So stages of TB hip and the foci, right? One, another MCQ I should be telling you here only. Whenever a patient, see what is common in all the 4 stages of TB. Common is flexion and flexion and flexion and flexion. And if you don't stop the flexion from happening, if you don't stop the flexion from increasing, what will happen? The patient is going to develop what? What we learn as the fixed flexion deformity, right? What we learn as the fixed flexion deformity of the hip. What does it mean? The fixed flexion deformity of hip. Now, what does that mean? If the patient is coming to you with the fixed flexion deformity of hip, what does it mean? He can't do which movement? He will not be able to do extension. That will fail, right? That will fail. So for fixed flexion deformity of the hip, what is the clinical test which is to be done? What is a clinical test which is to be done? So clinical test which is done to assess about the fixed flexion deformity of the hip is called as the Thomas test. Another MCQ for your exam, right? Whether it is NEET or INSET or FMG, everywhere they will ask you this, the Thomas test, right? So clinical test to assess the fixed flexion deformity of the hip, it has to be Thomas test, right? I'll share the screenshot, not to worry, but please keep on writing and just marking in your own workbook as well from wherever you studied. It's absolutely fine, right? So please don't forget this TB hip, the stages, the foci here, as well as this, the clinical test which is done, Thomas test. Okay, I hope it is fine with everyone. You all can now just, recall this tuberculosis topic as such is very, very important. So in this particular question, I don't think the question will be asked to you like this, right? True shortening can be seen in late arthritis also. This can be seen in advanced arthritis also. So it can be anywhere, right? So, but yes, the first stage where I can see true shortening is late arthritis. Advanced arthritis means when it is coming with wandering acetabulum, right? When it comes with wandering acetabulum. All right. I hope this is fine with everyone now. Okay. Now let's see the next one. Next one we have is 37-year-old male came into the clinic after RTA and excellent clinical examination finding is given in the images below. Which nerve is commonly damaged in such cases? All right. So they have just given you X-ray clinical examination finding is given below. Let's see what it is. Oh, can you make out what exactly this is? Can you make out what exactly? Look at this patient's presentation. Can you make out what is the presentation of patient here looking like? So his right hip, if you just make out, his right hip is how? Right hip has gone in, right? Right hip has gone in. The leg is going out. So when leg is going out, the hip has gone in, right? So what is this image trying to tell you? Internal rotation, yes. So it is telling you internal rotation. So post RTA, some patient has got an internal rotation attitude. What can be the most probable diagnosis? What can be the most probable diagnosis? Yes, it is adducted. I agree. Adducted hip and an internally rotated hip. What is it trying to tell you? What can be the possible diagnosis? If you can make out. X-ray is not suggestive of, much of the findings here. But yes, X-ray you might get confused, but posterior dislocation. Very good. So this is most likely a case of posterior dislocation. Now, if it is a case of posterior dislocation, yes, absolutely right. It is posterior dislocation of the hip joint. I hope I have given you that table in which condition the patient can come to you with what kind of attitude. I hope we have done that. Now, in posterior dislocation, what do you say? Which nerve should be affected? If the head of femur is going back, which nerve should be affected? Sorry. Sciatic nerve. Very good. So sorry for this. And if sciatic nerve is affected, what should be the presentation of the patient? What should be the presentation of the patient? Right? Sciatic nerve they give you or the common peroneal nerve they give you. Right? Bo, you know that common peroneal nerve is usually getting damaged around the neck of the fibula. Right? Common peroneal nerve usually gets involved around the neck of the fibula. Right? Around the neck of fibula. So what should be the presentation of the patient? What should be the presentation of the patient? What do you say? What should be the presentation of the patient? What do you say? I'll just wait for your answer. If somebody's sciatic, somebody's CPN is not working well, how the patient will be able to walk? Will be able to walk or no? How do you say it is going to happen? How do you say it is going to happen? So, it is going to present with what? It is going to present with a foot drop. And if somebody has developed foot drop, how the patient is supposed to walk? Yes, absolutely right. How the patient is supposed to walk? Patient will be walking with a high stepping gait. Right? Patient will have to make the limb go up so that the foot doesn't falls down. Right? It is going to be high stepping gait. Right? So it is going to be high stepping gait. Very good. Right? So do remember. Now, okay. See, whenever there is a posterior dislocation of the hip, one important sign which I want you to remember is something called as the vascular sign of Nareth. Right? Something called as the vascular sign of Nareth. Now, what is that? Sometimes they may give you this sign clinically also, by name also. The vascular sign of Nareth. Now, what is that vascular sign of Nareth? What is the meaning of that? Vascular sign of Nareth means patient won't be able to, when there is what kind of dislocation? We cannot palpate the femoral artery. The femoral artery is not palpable. Femoral artery is not palpable. In which dislocation? In which dislocation it will not be palpable? What do you say? The femoral artery is not palpable. In which dislocation? The vascular sign of Nareth, the femoral artery is not palpable. Why? Oh, why? Vascular sign of Nareth is anterior dislocation. Anterior अगर dislocation होगा, so please understand, अगर anterior dislocation होगा, तब भी तो femoral artery का base will be still intact, no? If, see, understand, from this side, the femoral artery is here. Let's suppose the femoral artery is here in front of us, right? Now, if the dislocation occurs anteriorly, the head still is going to come anteriorly. And if the head is going to come anteriorly, still the base of the femoral artery is maintained, isn't it?
If the head goes back, let's suppose this head is now going back. Now the base of the femoral artery is lost. So vascular sign of Nareth will be positive, in which case when there is a posterior dislocation of the hip, right? When there is a posterior dislocation of the hip, so it will be lost, right? Posterior dislocation of the hip, it will be lost. All right, I hope it is fine. Anterior is not the right answer, Zafa. I hope your point clear hua. So don't mark this wrong. That is a very, very important point here, right? That's a very, very important point here. Now let's move on to the next one. Okay, next one. Which deformity, what deformity is present as shown in the image below? What deformity is this? What do you say? What deformity is this? You can see there is a hyperextension part here at the proximal IP joint, right? Hyperextension here, and there is a flexion deformity here at distal IP joint. So DIP joint is flexed and PIP joint is extended. What do you say? DIP and the PIP. What do you say? What is that? The swan neck or botanier? Swan neck or botanier? This is swan neck, right? This is swan neck. Botanier will be just opposite of it. In botanier, what do we get? Swan neck. Yes, absolutely right. So in PIP, what will happen? The PIP stays extended, right? And there is a flexion. Yeah. So this is botanier we are writing. The PIP will be going into flexion and distal IP joint stays extended, right? That will be botanier. So botanier deformity will be something like this, right? Botanier will be something like this. This proximal IP joint, it is flexed, and distal IP joint, it becomes extended, right? Z deformity, it occurs because of carpal coalition. Now in the recently conducted INISET exam, right, there was a question asked that which level of vertebra is involved in rheumatoid. In RA, which level of vertebra is involved? You know that vertebrae are usually not involved, right? So in RA, which vertebra can be involved? Can you name it? Which vertebra can be involved? We say usually vertebrae are not involved. Which vertebra can be involved? Let me know about this. Which vertebra is involved in these cases? Any exception you remember? Any exception you remember? Cervical. Which cervical? Yashwant. Which cervical area? So it is cervical C1 and C2, right? Cervical C1 and C2, and this cervical C1 and C2 leads to atlantoaxial subluxation, right? That leads to atlantoaxial subluxation, right? So C1, C2, absolutely right. Now this atlantoaxial swan neck and Hubbardens, because I'll just tell you. See, देखो swan neck, this is fine, na? Atlantoaxial subluxation, this is fine with everyone. Okay, so now let me show you Hubbardens or swan neck में differentiation क्या है. Let me just tell you. See, देखो, I got this patient in my OPD. I'll just share something with you. See, look at this patient who came to my OPD. Something is wrong. I don't know what, but anyhow, I'll just show you this patient. Look at the hand of the patient here. So I got the history of the patient as the patient is having pain around the DIP and the PIP. Look at this picture. The patient is having pain around the DIP and the PIP. Now look at this. If you look at the hand of this lady, look at this. She is telling you pain at DIP and PIP. Can you see abnormal enlargements here? Can you see these abnormal enlargements here at the proximal IP joint and the DIP joint here? Can you see this? Right? Can you see this? If this is visible, can you see this? These kind of, swelled up areas on the DIP or the PIP, these are called as the Hubbardens or the Bouchard's nodes. Look at this. Look at all the fingers. If you can make out, look at all the fingers. All the fingers are showing you abnormality. Right? So these swelled up areas are the destruction arthropathies which are seen in the patients of osteoarthritis. These are the Bouchard's or the Hubbardens nodes. Right? These are Bouchard's or the Hubbardens nodes. But when you look at this deformity, now see how different it is. Now I hope you can make it out. In deformity, there is no swelling here, right? This is just a deformity over here. This is not a swelling. This is going to have a hyper. See, swan neck will be something like this, no? Look at this. This is swan neck. But when you look at the Hubbarden or Bouchard, you have to see my hand like this. So Hubbardens at DIP and Bouchard at PIP. Like this. Hubbarden and Bouchard. Okay. So DIP, PIP can be involved in OA. They are destroyed. But please remember, in RA, usually the DIP joint is not involved. I am saying joint is not involved, right? But do remember, this RA is a problem of synovium. right? RA is a problem of synovium, and because of synovitis, we can see the destruction, right? It's a problem of synovium, and because of synovitis, we see the destruction. Zafar, is it fine with you now? You'll be able to answer it accurately. You'll be able to answer it accurately. So everyone, I hope is clear about the deformity part. Oh, this you can diagnose. This you should diagnose. Diagnose the condition in the given X-ray of the ankle of a diabetic patient. See, clues are given here. 2 clues are given here. Okay. One is ankle X-ray is given of a diabetic patient. And what do we see in the X-ray? You can see there is some damage which has started occurring to the bones, the tarsal bones in the foot. Can you see? Calcaneum right now is fine, seems to be fine. Talus seems to be okay. And then cuboid, then the cuneiforms, kind of subluxation in the foot area. Yes, diabetes most often involves the foot region, right? This is Charcot's arthropathy. And you know, Charcot's arthropathy, the most commonest reason for Charcot's arthropathy is diabetes. Diabetes most commonly affects the foot region, right? Tabes, syphilis, it most often involves knee, right? The tabes dorsalis, it most often involves knee. And if by chance, sometime they give you the leprosy patient, leprosy most often involves the IP joint of the hands, right? Leprosy most often involves the IP joint of the hands. All right, that is fine, absolutely correct. So this should not be a tough one. Now this is very, very important. I hope nobody will be marking it wrong now. All right, so coming on to the next one also. Shall we do the next one? I have some more pages. I want to finish it up in next 1 or 2 day maximum, and then we can, let's do one more paper today. So identify the condition shown below. What do you say? What condition is this? Identify the condition which is shown below. Can you diagnose this condition? The fracture here is shown to be of, the question here is showing you an image fracture of the radius, and you can see the distal ulna getting subluxed. It is not in position. A, what is that? Galeazzi. Very good. It is Galeazzi. Very good. Fantastic. Okay. This is Galeazzi. Galeazzi and Monteggia. Okay. Galeazzi and Monteggia. You should be aware of both of them. Okay. They both are very, very important, topics for your exam. They both are very important definitely along with Coley's, which I have discussed already with you in the previous sessions, right? Which I have discussed with you in the previous session. So these three are very, very important. Okay, now please tell me, this you can easily answer now. This should not be tough for any one of you. This you can easily answer. 30-year-old has a history of trauma and pain in the right hip with flexion, abduction and external rotation. What is the likely diagnosis? Now please tell me from the table we have discussed earlier. I have given you one table. I do believe I have given you one table earlier, and that table was helping you out to understand what deformity means, what kind of pathology. I hope you all have noted it nicely. Okay, so what is this? B, anterior dislocation, abduction, external rotation, right? So trauma, flexion, abduction, external rotation are keywords, right? And that is anterior dislocation. Very good. In anterior dislocation, can you tell me in anterior dislocation, which structure will be most likely damaged? Which structure can be most likely damaged? In the anterior dislocation of hip, what do you say? Which structure will be most likely damaged? Which structure will be most likely damaged? What do you say? Hip anterior dislocation. What do you say? Which anatomical structure can be at damage? Femoral vessel. Very good. Anterior dislocations, femoral vessels. Posterior dislocations, sciatic nerve. Right? Very, very good. Now tell me about this. This is the easily diagnosed. You can easily diagnose it. 60-year-old female complains of pain in bilateral knee. 60 years, female, bilateral knee. So something has to be affecting both the joints at a time, right? The X-ray shows bilateral reduced joint space. What is the most likely diagnosis? Okay, what is the most likely diagnosis? What do you say? It has to be OA. RA, ankylosing spondylitis, will be most commonly affecting the sacroiliac joint. Then it will involve the spine. Right? Axial skeleton, I can simply write axial skeleton. So after sacroiliac joint, it will be axial skeleton. And hemophilic arthropathy again involves the knee, but why it will show up in a feature of, this feature will be in the patient of 60 years, right? So most likely it is a case of, most likely it is a case of OA only. Yes, you can easily diagnose that. Aha, very, very good one. Can you diagnose child with widening of the joint space presented with this kind of X-ray? where you can see lot and lot of changes, a very old pattern of asking you the questions, not the recent one, but if you can see these changes, see irregularities at every level, you can see irregularities. What are the options given? What is the commonest thing you can think about? Cupping, yes. What is the commonest thing you can think about? It is rickets, right? That's rickets. This I have discussed already with you. Please tell me the answer for this now. Spot diagnosis. Spot diagnosis. If this is spot diagnosis, what should I mention here? B, disc prolapse. Oh, come on. Okay, you are giving about number 4. You are talking about number 4. Tell me the answer for this one. The spotter number 5. Yeah, rickets is fine. Arpit, you are right. Meet right. Dawood right. Now tell me about this number 5. C, Klippel-Feil syndrome. I hope everyone remembers Sprengel's and Klippel-Feil, two entities, right? Sprengel's and the Klippel-Feil. Yes, very good. It is Klippel-Feil. Very good. Football player with knee injury diagnosed as a medial collateral ligament injury condition. Which structure is most commonly associated with this type of injury? Very interesting. If you can make out. Sorry. What do you say? Football player with knee injury diagnosed as medial collateral ligament injury. Which structure is most commonly associated with this type of injury? Posterior cruciate ligament. Oh no, it is MCL बेटा. MCL है. MCL के साथ में most commonly कौन सा structure involved होता है? PCL. No. सोचो. Let me give you the clue. Lateral menisci है. Oh. Medial collateral के साथ lateral. गड़बड़ हो गया. Remember something called as terrible triad of knee. Remember something as the terrible triad of knee. क्या structure होता है एक साथ? Damage. Whenever there is an injury to the medial collateral ligament, there is a high possibility of injury to the anterior cruciate ligament, ACL, or the medial menisci. Right? Medial menisci. So terrible triad, all on the medial side of the knee. All on the medial side of the knee. The femur here, the tibia here, right? Fibula here, and you have the ligamentous structures. The medial ligament, lateral ligament, right? ACL and the PCL. The menisci here. Okay, the menisci here. So structure 1, the medial collateral. Structure 2, the ACL. Structure 3, the medial menisci. This is called as the terrible triad of knee, right? The terrible triad of knee. Don't miss it out. This is even one of the most important MCQ for your exam. The medial collateral, terrible triad. Terrible triad is medial collateral ligament, anterior cruciate ligament, and the medial menisci. Right? The medial structures getting damaged is what you call as terrible triad. This can be a potential MCQ. Okay? So it is not the PCL or the lateral menisci. Got this? Meet, you are right. Absolutely, you are right. Medial collateral ligament, medial menisci, and the ACL. Yes, terrible triad. Okay, terrible triad of knee. Okay, or the O'Donnell's terrible triad. Very good. Avian of the femoral head is most commonly due to which of the following arteries? Now tell me about this. Anatomy, little bit of anatomy. We have to recall from anatomy as well. Which artery is the most important one? If damage will lead to high possibility of leading to the avian. Femoral head blood supply. B, lateral. No. It has to be not lateral. It has to be medial. Medial circumflex femoral artery. Right? Medial circumflex femoral artery. It has to be A. Dekho. Not B beta, it is A. Medial circumflex femoral artery. Avian of the head of femur is most commonly occurring not because of obturator artery. Profunda is the main supply. See, dekho. When you look at the proximal femur, okay, I'll just draw here. When you look at proximal femur, like this, okay, when you look at this proximal femur, now from the femoral artery, let's suppose this is femoral artery, right? I'm just drawing a very rough sketch. Let's suppose this is femoral artery, right? From femoral artery, there comes a branch which is called as the profunda femoris artery. This is profunda femoris. Okay, so this is the femoral artery sending the blood down, and this is the profunda femoris artery which is going down like this. Now this profunda femoris gives you two branches. one which is in the anterior side of the head of the femur and ends here in the piriformis fossa, right? And one which goes from backside and again makes anastomosis here in the piriformis fossa. Now the supply in the front is lateral circumflex femoral artery. The supply behind is medial circumflex femoral artery, right? Posteriorly, you have got more of the pressure and the more of the weight bearing area, right? Now these two are going to supply the head of the femur like this, lateral from the front and medial from the back. And being more pressure on the posterior aspect, we get more of the necrosis on that side. That is why medial circumflex femoral artery is more important vessel for us, right? So most important when they're asking you, it has to be medial circumflex femoral artery. Is this fine now? Is this fine? C, B, Deepika, Meet, Arpit, Yashwant, Daud, everyone, you answered B or C. Is it fine now? Medial or lateral, what you are going to mark? The medial circumflex or the lateral circumflex, what you are supposed to mark? So always we go with the medial circumflex femoral artery, right? Profunda femoris is the major vessel, is the main supply. Profunda femoris is here. It is a main supply giving the branches of lateral and the medial circumflex. All right. Okay. Now see, next one. Which of the following finding can be noted in initial stages of TB? बताओ. Initial stages of TB में थोड़ा सा tricky है, सोच के जवाब देना. And it's easy. If you just, if you just put some logic into it, you'll find the answer. Don't go traditional way of mugging up, learning up like that, table only. B, सोच के बोलना. Can be noted in increase in the joint space. B, you're saying this one, joint space. बताओ. Next one. What do you say? Joint effusion नहीं मिलेगा. Increase in joint space. So both seem to be fine, right? Joint effusion होगा तो joint space बढ़ सकता है, which is true. But दोनों options एक साथ मिलना, I don't think it's a possibility, right? I don't think so. It is a possibility. So there might be okay. There might not be a possibility that you are getting both of them at a time. Okay. All right. So now, okay. So these were your questions from the these PYQs of your FMG examinations, right? Now देखो, in question को solve करते करते भी we understood so much that if you are lacking concept, it might become difficult for us to answer anything in the exam, right? So I would highly recommend to all of you कि एक बार whatever GT you have given recently, right? Whatever GT you have given recently, just review that and start working on the weakest subject. Okay? Try not to mug up. PYQs important है, but PYQ से ज़्यादा important है PYTs. और PYTs कब solve होंगे? When you have the idea about the concepts, right? Whether it is my subject or any other subject. So अभी I have plans to take some more sessions with you. Some I think more 3 years of paper or 3 sessions of paper I have left for you to discuss, and after that I can discuss the highly probable MCQs from my subject or my relevant part of anatomy or radiology, or you can say medicine part. So we'll discuss that also. Okay, so now I'm very, very sure that each one of you is again preparing well and staying on the right track. Start changing your daily routine, daily life cycle as per the exam day. ठीक है, उठने की आदत डालो टाइम से. Give a test whenever you're planning your GT, whenever you're planning your subject wise test. Make sure you're planning at the same time when you're about to give your main examination, right? उसी time पे plan करो, so that your mind is most active and you don't feel lethargic, you don't feel sleepy, right? Will do. Now whatever is like part of anatomy, most of it, 90%, I think 80-90% is usually covered up with surgery or orthopedics, right? So I'll take that also. So I have this August 2020 with me. August के बाद में I think 1 or 2 more papers are here, and then we'll discuss the recent papers. I'll go till 19. So we have reached to now next paper will be August 2020, and last I'll be taking 19. And after that I'll come on to the recent paper of the recent session. उसको discuss करेंगे, and then we'll move on to anatomy part, right? उसके बाद anatomy शुरू कर देंगे हम. Okay. So I hope getting up early in the morning is worthy with these discussions, which are going to be very, very fruitful and going to help you out in your exam as well. Chalo, lot of time taken from your side as well, almost more than 50 minutes. All right. So have a wonderful day, have a productive day, and make sure that when you are done with your very good. Arpit, thank you so much. And अब बस उठ गए हो तो now
stay on the track and start just with your day. Whatever you have planned for the day, it has to be a productive one, not a stressful one, right? Stress लेने के लिए और बहुत सारी चीज़ें पड़ी हैं and पूरी लाइफ पड़ी है, but अभी के लिए it has to be a happy day, healthy day and a wonderful day. So utilize it very, very properly. See you again maybe tomorrow morning, right? Tomorrow morning I'll be not in Delhi, I'll be somewhere out, so I'll just see if the network connection is good. I'll join you tomorrow morning. I'll keep you posted. Okay, so I'll update you today itself by late evening, I think, and see you all again tomorrow morning. All right, so have a wonderful day, guys. Have a productive day. See you all again tomorrow morning. And yes, session is awaited from the mentor due for all of you, and we are going to do that also very, very soon, right? So don't ever think that your mentor due is not here, your 5am sessions are not here, and we are not there to support you. We are always there to support you, and we are going to make a session very, very soon for you, right? So see you all. Have a great day. Thank you so much, everyone.